Part A. Extract 1. Questions 1 to 12. You hear a dermatologist talking to a patient called Mihiraa. You now have 30 seconds to look at the notes.
Hello, Mihiraa. Please come in. What brings you to see me today?
Thank you, Dr. Vance. I'm a bit concerned about my skin. It's been quite troublesome lately.
I see. Can you describe what's been going on?
Well, for the past few months, I've developed these really persistent red patches on my elbows and knees.
All right. Mihiraa, do they tend to cause discomfort?
They're quite scaly and incredibly itchy, especially at night. I've tried moisturizing a lot, but it doesn't seem to help much. Sometimes they can feel a bit sore if I scratch them too much. I've also noticed my nails seem to be getting thicker and a bit discolored, almost yellowish on some fingers and toes.
Noted. And have you experienced any joint pain or stiffness, particularly in the mornings?
Yes, actually. I almost forgot to mention that. My fingers and toes sometimes feel stiff when I wake up, and a couple of my joints, like in my knee, have been aching intermittently. I just put it down to getting older, but it has been more noticeable recently. Since they're quite visible, it makes me feel self-conscious.
I understand. Have you tried any over-the-counter creams or treatments for these patches?
I've tried various heavy moisturizers, including those meant for intense hydration and barrier repair, and even some hydrocortisone cream I had at home, but nothing seems to make them go away. They just keep flaring up. Despite temporary relief, the redness tends to return with the slightest trigger or environmental change. I've also tried using milder soaps and detergents.
That's helpful to know, Mihiraa. And regarding your medical history, do you have any family history of skin conditions or any other significant health issues?
Yes, my mother had something similar. I think it was psoriasis, but it wasn't as severe as mine seems to be. Apart from that, I'm generally healthy. No major illnesses or surgeries except for PCOD, which is being managed with metformin and Nordet.
Thank you, Mihiraa. From what you've described, particularly the scaly red patches, intense itching, nail changes, and joint stiffness, it sounds consistent with psoriasis. It's a chronic autoimmune condition that causes skin cells to build up rapidly on the surface of the skin.
Oh no. What do we do now?
To confirm the diagnosis and determine the best course of action, I'd like to do a skin biopsy from one of the affected areas, which will give us a definitive diagnosis. We'll then discuss various treatment options, which can range from topical creams to light therapy or even oral medications, depending on the severity.
All right, thank you, Dr. Vance.
Extract 2. Questions 13 to 24. You hear a neurologist talking to a patient called Mihiraa. You now have 30 seconds to look at the notes.
Hello, Mihiraa. I'm Dr. Finch, the neurologist. What brings you to see me today?
Hello, Dr. Finch. I've been having some really strange symptoms lately, and my general practitioner thought I should see a specialist.
I see. Please tell me more about what you've been experiencing.
It started a few months ago. I've been getting these episodes of dizziness, almost like the room is spinning. They come on quite suddenly. Sometimes I feel like I might faint.
All right. And how long do these episodes typically last?
They can vary, anywhere from a few seconds to a minute or two. What's really concerning is that sometimes I also experience numbness on one side of my body, usually my right arm and leg. It's not constant, but it's very unsettling when it happens.
I understand. And Mihiraa, do you notice any specific triggers for these episodes?
Not really clear triggers. They seem to happen randomly. I've also been having frequent and intense throbbing headaches. They're different from my usual tension headaches, sometimes come with sensitivity to light and sound.
Thank you, Mihiraa, for that detailed description. Have you experienced any changes in your vision, speech, or memory?
Yes, sometimes my vision gets blurry during these episodes, or I see flashing lights. And I've noticed I occasionally struggle to find the right words when I'm speaking, which is very frustrating. My memory also feels a bit off lately, like I'm forgetful of things I should easily recall.
I see. And have you tried any remedies or over-the-counter medications for these symptoms, Mihiraa?
For the headaches, I've tried regular pain relievers, but they don't really touch these new, intense ones. For the dizziness, meclizine, but for numbness, I haven't tried anything specific because I don't know what it is. I've just been resting when they occur.
Right. And your medical history, Mihiraa? Any history of migraines, strokes, or other neurological conditions in your family?
My grandmother had migraines, but nothing as severe as this. No history of strokes or anything else neurological in the immediate family that I'm aware of. I do have high blood pressure, which is generally controlled with furosemide.
Thank you. Mihiraa, based on your symptoms, we need to investigate this thoroughly. This constellation of symptoms could indicate a few different neurological conditions.
What sort of conditions?
It's too early to say definitively, but we'll consider possibilities such as migraines with aura, or conditions affecting blood flow to the brain, or even something like transient ischemic attacks, TIAs, which are often called mini-strokes. To get a clearer picture, I'll need to conduct a comprehensive neurophysiological examination here in the office.
Okay.
In addition, I will most likely order some imaging tests, such as a brain MRI, to look for any structural changes or abnormalities. We might also consider a carotid ultrasound to check the blood vessels in your neck. These tests will help us pinpoint the cause of your symptoms and determine the most appropriate course of treatment.
That makes sense. I just want to understand what's happening.
Absolutely, Mihiraa. We'll work together to get to the bottom of this.
B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen. Now look at question 25. You hear a nurse called Mihiraa talking to a colleague. Now read the question.
Clara, I just got handed over a new patient, Mr. Bernard Ellis. It's quite a complicated case. He's a 68-year-old with a history of COPD, but he's been admitted now due to a suspected silent myocardial infarction. Initially, they thought it was a COPD flare because of his breathlessness and fatigue, but the troponin levels told a different story.
Silent MI? That must have been a tough call. How stable is he now, Mihiraa?
He's stable but very fatigued. He also has type 2 diabetes and mild dementia, which makes the picture even trickier. His sugars are erratic, and he forgets he's eaten. Plus, he's been showing signs of orthostatic hypotension, especially this morning during assisted mobilization.
So Mihiraa, what's the priority in terms of his care right now?
Well, the cardiology team wants close cardiac monitoring for arrhythmias, but Dr. Samuel stressed that fall risk should guide our immediate interventions. They're more concerned he might fall again like he did last week at home, even before the cardiac episode was suspected. That seems to be their main concern for now.
Now look at question 26. You hear a doctor called Mihiraa talking to a junior doctor. Now read the question.
James, have you had a chance to look over Mr. Harrison's chart from yesterday?
Yes, Dr. Mihiraa. I reviewed the notes and the latest labs this morning. His inflammatory markers are still elevated, though perhaps not quite as dramatically as the initial presentation suggested.
Right. And the imaging? What did the repeat scan show regarding that area of concern we discussed?
The radiologist's report is in. It confirms the previous finding in the lower quadrant, but they've added a note about the adjacent structures. It appears that what we initially thought was simple edema is now described with slightly more specific terminology, indicating a degree of involvement we hadn't fully appreciated from the first images. It's subtle, but they've highlighted it.
I see. So, the extent is perhaps a little broader than anticipated?
Exactly. It makes sense of why he's still reporting that persistent, low-grade discomfort despite the initial course of antibiotics. We were targeting the primary issue, but this secondary involvement explains the ongoing symptoms.
Understood. Let's ensure the plan reflects this. We'll need to broaden our approach slightly.
Agreed, Dr. Mihiraa. I'll update the notes and speak to the pharmacist about adjusting the prescription.
Good. And keep a close eye on his temperature trends today.
Now look at question 27. You hear a social worker called Mihiraa talking to a GP. Now read the question.
Good morning, Dr. Alastair. I wanted to briefly discuss a new patient referral, Mr. David Miller. He's presenting with significant anxiety and some sleep disturbances, which isn't entirely unexpected given his recent diagnosis. However, he's also expressed concerns about managing at home, mentioning difficulties with meal preparation and remembering his appointment times. His daughter, Sarah, is quite worried about him being alone for extended periods. She's mentioned a previous fall he had a few months ago, although he wasn't seriously injured then. He also seems quite isolated, mentioning a decline in contact with his neighbors since his wife passed away last year. Sarah is particularly concerned about his emotional well-being and the practicalities of his daily living now. Thank you, Mihiraa. That's a helpful overview. So, the primary concern from your perspective is his ability to cope independently at home, considering both the emotional impact of his diagnosis and these practical challenges with daily tasks? Precisely. While the anxiety and sleep issues are certainly present, Sarah's anxieties and Mr. Miller's own concerns point towards a potential struggle with maintaining his independence and safety outside of a structured care setting.
Now look at question 28. You hear an occupational therapist called Mihiraa talking to a patient. Now read the question.
Good morning, Mr. Thompson. How have you been managing since your last visit? I see here you've been working on the grip strengthening exercises we discussed.
Morning, Mihiraa. Honestly, it's been up and down. The exercises help, but I've been struggling with the jar opener you recommended. My wrist still twinges when I twist. And now my shoulder's acting up when I reach for things on high shelves.
I see. The wrist pain is concerning. Have you been alternating hands when using the jar opener like we practiced?
I try, but I forget sometimes. The shoulder's worse, though. I had to stop midway while painting the ceiling last weekend.
That's important. Painting overhead is strenuous. For now, avoid repetitive reaching. Use a step stool to reduce strain. Let's also adjust your wrist exercises. Focus on stability, not just strength.
Got it. What about gardening? I've been avoiding pruning since it hurts my wrist, but I miss it.
Pruning requires forceful gripping. Try lightweight shears and take breaks every 10 minutes. Prioritize shoulder rest this week. We'll reassess next time.
Now look at question 29. You hear a GP called Mihiraa talking to a surgeon. Now read the question.
Good morning, James. Thanks for taking my call about Mr. Harrison. Mihiraa began, reviewing her notes. He's been experiencing significant right-sided abdominal pain for the past week. Initially, I suspected gastritis, given his history of occasional indigestion, and started him on antacids. However, the pain has intensified and is now localized more in the lower quadrant. He mentioned some nausea, but no vomiting.
Right-sided lower quadrant pain, you say? Has he had any changes in bowel habits? Any fever or urinary symptoms?
No significant changes in bowel habits reported, and no dysuria or increased frequency. He did mention feeling slightly warmer last night, but his temperature was normal in the clinic this morning. The tricky part is that he also has a history of mild diverticulosis, diagnosed a couple of years ago, which has been asymptomatic until now. So, while appendicitis is certainly on my radar given the location and increasing severity of the pain, I can't completely rule out a flare-up of his diverticular disease.
I understand. Given the persistent and worsening localized pain, despite the lack of definitive fever or bowel changes, Mihiraa, I think it would be prudent to get him in for an urgent surgical assessment to properly evaluate for acute appendicitis. The diverticulosis history adds a layer of complexity, but the clinical picture you're describing leans more towards an acute inflammatory process in the appendix. We can always investigate the diverticulosis further if the appendix turns out to be unremarkable.
That aligns with my thoughts, James. I'll arrange for him to come to your clinic this afternoon then. Thank you for your prompt advice.
Now look at question 30. You hear a nurse called Mihiraa talking to a doctor. Now read the question.
Dr. Lawson, can I give you a quick update on Mrs. Janet Rowe's morning review? She's the 73-year-old on the post-op ortho list. Total hip replacement, day 4.
Yes, go ahead, Mihiraa. I remember she had a few flags yesterday.
Right. Her BP's been hovering around 90/56 since early morning, and she felt lightheaded during physio, but she insisted it was just poor sleep. Her HB dropped slightly overnight to 92, though her wound site is clean with no signs of active bleeding. She's also refusing the high-protein supplements, saying they upset her stomach.
Could the lightheadedness be anemia-related or postural?
Possibly both, but her postural readings were fairly unchanged, and she was already on slow mobilization. What's strange is that she didn't eat anything yesterday apart from a few sips of tea, and this morning she vomited after just a few mouthfuls. No fever or infection markers, but she's definitely dehydrated. Her urine's dark and output is low.
Then the nausea might be the culprit behind everything else. Mihiraa, let's start with antiemetics and adjust fluids. Address that first.
That is the end of Part B. Now look at Part C. Part C. Extract 1. Questions 31 to 36. You now have 90 seconds to read questions 31 to 36. You hear the conversation between the head of the emergency department, Dr. Mihiraa, and an interviewer.
Dr. Mihiraa, thank you for joining us. Emergency departments are often considered the front line of hospital care. Can you tell us if there are any monitoring systems in place to manage patient influx and departmental operations?
Absolutely, James. Over the past 5 years, our department has integrated a multi-tiered clinical operations dashboard designed not only to monitor patient flow in real time, but also to alert us to surges in caseload or when our waiting times exceed critical thresholds. The system doesn't just track numbers, it stratifies incoming cases by triage level, enabling preemptive resource redistribution. However, it's worth noting that while the system flags high-pressure points, human interpretation and senior clinical oversight remain central to the decision-making process.
That sounds incredibly sophisticated. Could you break down what exactly this system comprises?
Sure. It's composed of 4 interconnected layers. The first is the real-time admission tracker, which feeds data from triage nurses into the system as patients arrive. Second, we have an acuity-based load balancer that reassigns cases dynamically between zones. Then there's the staff allocation interface. This one pulls rosters, identifies which teams are approaching saturation, and recommends reassignments if required. The final layer is a retrospective analytics module, where every week's data is compiled for root cause analysis. But perhaps what gives it true value is its predictive capacity. It applies machine learning algorithms to forecast likely congestion patterns based on seasonality, staffing profiles, and even local events.
Fascinating. Now, shifting a little, given the intensity of emergency care, how conscious is your department of the well-being of its healthcare staff?
That's a question I'm particularly glad you asked. In emergency medicine, burnout is not a distant threat, it's a constant. We're acutely aware of the toll sustained adrenaline and emotional strain can take. One major initiative was introducing the decompression zone, a quiet off-clinical space for staff to retreat to during peak hours. We've also made reflective debriefings mandatory post-critical incidents, not just for quality improvement, but for emotional processing. It's embedded now in our departmental rhythm. Moreover, our recent collaboration with occupational health allows us to actively track physiological indicators like sleep rhythm and hydration levels through wearable devices for voluntary participants. This proactive stance on health is no longer a luxury. It's part of ensuring clinical safety.
That's genuinely progressive. From an administrative perspective, how do you evaluate whether the department is running efficiently?
Efficiency here isn't just about moving patients out fast. We evaluate based on 5 dimensions: patient outcomes, time to intervention, representation rates, staff response times, and interdepartmental escalations. For example, if time to intervention increases but patient outcomes remain high, we might be improving prioritization quality. We use blended scorecards, combining objective metrics with qualitative feedback from both patients and staff. It's more nuanced than raw statistics, which can be misleading in an ED environment. For instance, a patient waiting 40 minutes but receiving empathetic care may rate the experience higher than one who waits 10 minutes with little interaction.
And how often is this evaluation done? More importantly, when inefficiencies are found, are measures taken promptly?
Yes, we maintain a rhythm of fortnightly operational reviews. But the real-time dashboards allow mid-shift adjustments too, especially during red alerts. When the scorecard reveals underperformance, we run a rapid cycle improvement protocol. It's a 3-day sprint involving a representative team, from junior nurses to consultants, who analyze the weak point and test micro-adjustments live. This agility ensures that correction isn't buried in paperwork. It's immediate, responsive, and measurable. Just last month, we noticed a dip in our handover to intervention times on night shifts. Within 72 hours, we trialed a modified role distribution for senior night registrars, and the metrics bounced back above baseline.
Lastly, could you share any latest advancements the department has implemented?
Certainly. The most transformative has been the integration of augmented triage via natural language processing. Our digital intake clerk now listens to patient histories and simultaneously generates risk stratification profiles, which are reviewed by a triage nurse. It's shaved nearly 4 minutes off average intake. Another major shift was the pilot of wearable diagnostics in the waiting room. Patients wear a wristband that tracks vitals continuously, and significant changes trigger alerts before the patient even voices symptoms. But the advancement I'm most excited about is our partnership with AI radiology interpretation for musculoskeletal injuries. Early detection of occult fractures has improved, especially in younger patients who otherwise get overlooked in high-pressure settings. Now look at Extract 2. Questions 37 to 42. You hear a presentation by Dr. Linson Huge, consultant orthodontist at Mihiraa Healthcare Institute. You now have 90 seconds to read questions 37 to 42. Good morning, everyone. It's both an honor and a pleasure to share with you today the recent advancements and strategic innovations being pioneered at Mihiraa Care, a name that is fast becoming synonymous with excellence in multidisciplinary medical research and advanced clinical practice. As a senior consultant orthodontist and clinical lead in applied craniofacial technology, my exposure to our broader institutional ecosystem at Mihiraa Care has revealed a unique synergy between clinical precision, research depth, and tech-driven patient care. Let me begin by outlining the key domains where Mihiraa Care is concentrating its development. While my own department primarily revolves around dental and maxillofacial systems, the Institute's architecture is anything but narrow. The key sectors currently under innovation include neuromuscular rehabilitation, tissue engineering, AI-supported diagnostics, metabolic disorders, and biomechanical integration in orthodontics and orthopedics. What's notable is that each sector isn't siloed. Instead, there is deliberate cross-collaboration. For instance, we've seen AI-powered cranial mapping models initially built for neurology adapted for orthodontic growth pattern prediction. This vertical integration approach ensures that discoveries in one specialty often catalyze developments in another. Now, when it comes to conducting research at Mihiraa Care, the methodology is layered, iterative, and uniquely integrative. Studies begin as clinical observations, often triggered by pattern anomalies noticed in long-term patient cohorts. These triggers are translated into hypotheses that undergo peer validation before entering trial phases. A defining characteristic of our research model is its cyclical clinical feedback loop. Unlike many centers that separate data collection from treatment, at Mihiraa Care, we embed digital analytics into real-time interventions. This means that patient feedback, biomarker response, and behavioral data inform the progression of the study, while the study itself continues to shape ongoing patient management. It's dynamic and requires constant recalibration, but the outcome is remarkably context-aware research. Supporting this is an ecosystem of high-functioning facilities tailored for multidimensional research. The recently upgraded Craniotech Lab, situated in the East Tower, is a flagship facility for 3D morphometric studies and microstructural mapping. Adjacent to it is the Interventional AI Suite, where machine learning models are trained on anonymized case histories and diagnostic imaging. Furthermore, Mihiraa Care has invested in the creation of the Biosensory Diagnostics Wing. This is where patient-derived biosignals are processed to identify real-time adaptive responses, which is groundbreaking for procedural customization. And, notably, the staff composition in these labs is multidisciplinary by design, with clinicians, data scientists, ethicists, and biomedical engineers working together on concurrent objectives. How does this level of infrastructure and methodological clarity feed into practical innovations? Take, for example, our orthodontic intervention models. Thanks to data streaming from the biosensory wing, we can now design braces that adapt their tension based on salivary enzyme fluctuations indicating bone remodeling thresholds. That sort of interface between biology and hardware would have been speculative just 5 years ago. And it's not just devices. Mihiraa Care's innovations extend into procedural philosophies. We've shifted from symmetry-focused interventions to growth harmony models, particularly for adolescent patients, acknowledging asymmetry as a biologically useful state rather than a cosmetic defect. The way we analyze these developments is another domain where Mihiraa Care differentiates itself. Rather than simply relying on endpoint analysis, such as treatment success at 12 months, we perform mid-phase adaptive analytics. This approach tracks secondary indicators like psychological response to therapy, patient-reported comfort fluctuations, and localized tissue responses. All this is then visualized through our multi-phase outcome grids, enabling clinicians to observe trajectories rather than static results. That level of granularity allows us to intervene proactively, often before clinical symptoms surface. We also employ post-study cross-functional reviews, where departments evaluate whether the observed innovations are translatable or require contextual modifications before rollout. Looking ahead, Mihiraa Care is directing its next phase of development toward microfluidic diagnostics integrated within oral appliances. These devices will continuously monitor and transmit data on electrolyte shifts, microbial flora transitions, and inflammatory markers, offering a preventive layer to dental and systemic care. In parallel, our long-term focus is on telemetric orthodontics, aligners that not only adjust incrementally on command, but also communicate biomechanical changes to the practitioner remotely. We're already piloting Phase 1 in collaboration with 2 European partners. In the broader context, Mihiraa Care is placing significant emphasis on establishing behavioral models that predict patient adherence based on cognitive emotional mapping, potentially transforming how interventions are structured in both duration and delivery. In closing, Mihiraa Care's advancements are not simply technological. They are conceptual, integrative, and deeply rooted in patient-responsive evolution. What makes it a standout institution is its refusal to treat healthcare as a linear equation. Instead, it embraces its complexity, builds systems that are flexible enough to adapt, and above all, keeps the patient, both as subject and collaborator, at the heart of its progress.